انتوا عارفينها احسن مني الدكتوره صفاء. فان شاء الله النهارده الدكتوره صفاء هتتحفنا بمحاضره جميله نستزيد علم من خبرتها وكل ده التواضع الجميل بتاعها. وانا بشكر طبعا الناس اللي عندهم صبر وطولة بال وعارفين قيمه الدكتوره صفاء كويس قوي، قاعدين لغايه الساعه 5 و6 وحاجات كده، وحتى لو قعدنا ل 10 بالليل هنقعد للدكتوره صفاء. اتفضلي يا دكتوره صفاء.
دكتور احمد، والله انا ده اكبر ما استحقه. حضرتك اللي ما شاء الله متواضع، والعلم ما شاء الله حضرتك والدكتور هشام شرفتونا طبعا، وشكرا انك انتوا جيتوا في الوقت ده طبعا من الجو الرائع اللي احنا كنا عايشينه. ففعلا انا زي ما بقول كده ان الضيوف بتوعنا جم وجابوا الشمس معاهم. وشكرا والله، جزاكم الله خير، التقديم اكتر من استحق بصراحه.
حبيبتي الله يخليك.
وشكرا على صبر اي الاودينس طبعا ان هم يستنونا لغايه دلوقتي، ومعلش يستحملونا اخر نص ساعه كده ان شاء الله. انا مش هطول عليكم لان انا فعلا بخلص يعني. التوك بتاعتي النهارده عن الهيلثي ايجينج ان ادلتس وذ سيريبرال بولسي. كتير احنا بنشوف حالات سيريبرال بولسي في اليونج ايج، لكن قليل ان احنا كونسيدر التشينجز اللي بتحصل لهم while passing in their life span. This is my disclosure. Several disabilities are encountered in CP. 1 in 3 are unable to walk, 1 in 4 are unable to talk, 3 to 4 having pain, whatever in whatever area in the body. Several abnormalities, including inability to sleep, cognitive problems. Transition to adulthood. Although CP is a static process, but dynamic changes occurs while they're passing in the adulthood. Development of additional health problems lead that the adults with CP need health services for continued monitoring and management of their conditions. The first to speak about is CP mortality and life expectancy. While speaking about the mortality in CP, we should consider 2 periods in their life. The first one is survival through infancy and childhood into adulthood, and the other one is the survival in adulthood. Most of the morbidity and mortality occurs while the patient is infancy and early childhood, but mostly it is difficult to be diagnosed as CP as there is critical problems in the systems of the patient that leads to death before being diagnosed as CP. While passing in the adulthood, several problems occurs also, which leads to death of the CP in their adult age. Most probably it's cardiopulmonary and respiratory. CP patients in the adulthood having higher rate of chronic conditions such as diabetes, asthma, stroke, emphysema, and other heart problems than their peer non-CP patients. Age is identified as the strongest independent predictor of vascular health. To solve this problem, annual checkup for such morbidities is recommended with the prescription of regular exercises that truly decrease the incidence of such cardiopulmonary problems. Deterioration in the physical activity. In adults with CB, physical activity was reported to decrease with both decreased GMF score and level and with aging. Children are either born or acquire cerebral palsy at very young age, so many don't understand what typical movement is. Many of the CP children, while they're passing in their lifespan, will define their movement according to their physical abilities and the spasticity they encounter. Little is found in the literature about the evidence of teaching these patients how to move properly within the older age. They failed because they move according to what was habitual to them while they're passing in their lifespan. So treatment of the disabilities, physical disabilities, special spasticity in CP is very fundamental to develop later on a program that habituates the patient for their normal movement. Musculoskeletal issues are also encountered in CP patients while they're in adulthood period. Adults with CP are more prone for osteoporosis because of vitamin D deficiency. The causes of vitamin D deficiency is being limited to indoor, little mobility, little weight bearing, decreased intake. This could be treated by encountering and putting in mind that osteoporosis is more prone to be developed in CP patients while passing in their adulthood, giving them enough vitamin D, exposing them to sun, encourage exercise, weight-bearing exercise, and encourage them even to stand without movement. Evaluation with DEXA annual, and giving exercises. Developing of protocols to encounter osteoporosis as regards diagnosis and treatment for this population. Scoliosis is also encountered in CP patients because of their inability to move, the presence of spasticity, the incompatibility of the wheelchair they are being sitting in. Scoliosis causes a lot of pain to the patient, loss of mobility, loss of function. It could be treated by regular examination. The degree of scoliosis is increasing each year by about 1 degree. Custom molded seating and posture through thoracolumbar orthosis is mandatory for these cases. Spondylolysis is also encountered in these cases with fracture in the pars interarticularis due to the development of osteoporosis in these cases. With dyskinetic movement and involuntary movements, spondylolisthesis could develop, which will lead to cervical stenosis and myelopathy. Hip dislocation is also encountered with spasticity. Early identification is important. The condition is severely painful, disabled, leading to decrease in the function of the patient, and a vicious circle the patient is put in. Total hip arthroplasty may be the end result. The knee also is involved as a burden. Patella alta is commonly encountered due to the crouch gait. Actually, the crouch gait could be developed either from the start or after treatment from the orthopedic surgeon if he corrected the plantar flexion only, without considering the hip and knee flexion. Working on the crouch gait as early as possible is important before the development of patella alta and other congenital anomalies or other follow-up deformities that could be encountered later on and impair the function of the patient and needs our intervention. Sarcopenia is also encountered in the CP children and increased with age, although they may appear obese, but the increase in the body weight is encountered due to increase in the fat amount with decrease in the muscle bulk, fatty infiltration of the muscle. The muscle will not act on the bone, decrease the muscle bulk, lead to osteoporosis, further osteoporosis, decrease in the function. This could be corrected by increase the protein intake, frequent exercise, and supplementation with vitamin D. Pain could be encountered from every structure in the CP child, either muscle, joint, nerve, contracture, orthopedic deformities, fracture, pressure ulcer could also be a cause. It decreases the function, deteriorates the quality of life. We should identify painful causes, especially if the patient has cognitive impairment. Early and adequate control of pain is mandatory because pain is a stimulus for increasing the spasticity. These are examples for neurological changes being faced by the adult of CP children. They face double the risk for stroke, 8 times for myelopathy. At least a third of them will lose mobility, and most of them having pain in the back and other areas. Myelopathy, as we discussed before, may be caused because cervical stenosis, very dangerous, may be treated surgically, but usually the surgical intervention is not enough because the actual cause is osteoporosis, spondylolysis, spondylolisthesis, together with the spasticity around the cervical area, with abnormal movement that could develop and dystonia. So working by MRI every 2 years to distinguish this case, especially if the patient is already bedridden. Botulinum toxin is important and a cornerstone helping in minimizing cervical dystonia. Medications that could control dystonia with putting the patient into a more calm environment in order not to irritate him and improve the condition quickly. Neurogenic bladder. It do exist in cerebral palsy in about 15% of the population, seem to be more common in those with bilateral involvement. It occurs equally males and females. Frequency and urgency is most encountered in these cases with hyperreflexic bladder. Anticholinergic medications can often relieve the symptoms and provide continence in the absence of urinary retention. For urinary retention secondary to detrusor sphincter dysynergia, injection of botulinum toxin A into the pelvic floor muscles relieve the hypertonia and outflow obstruction. So asking more questions regarding bladder function in individuals with CP across their lifetime may diagnose this case before being complicated by renal problems. Nutritional changes and dysphagia. There is a higher prevalence of dysphagia in such population. Adults with CP, despite maintaining the same dietary patterns as in childhood, may experience gradual deterioration of their swallowing and milestone capabilities and mealtime capabilities. Videofluoroscopic swallowing study revealed frequent aspiration without cough reflex, probably due to abnormal sensory motor integration or chronic aspiration-induced desensitization of the laryngeal airway. To solve this problem, regular follow-up with speech-language pathologist annually or biannually to detect these cases before developing aspiration pneumonia with the problems that could lead them to death. Functional limitations also is impaired with age. Aging per se is a predictor for development functional limitations. We may find the patient after 2-3 years with improving his functional abilities. Then after 20 years age, the deterioration of functional level was encountered. This is normal. The deterioration occurs at late 20s and early 30s. If the functional score is deteriorating, that means that the cerebral palsy patient, it becomes a more burden on his healthcare providers. Recently, there is a move to develop international classification of function disability for adults with CP. Spasticity. Spasticity persists beyond growth and development as a common threat to optimal function in adults with CP. Botulinum toxin is a key cornerstone in treatment. It can be particularly important for those individuals with dystonia to decrease the incidence of myelopathy. Adults with CP may benefit from intrathecal baclofen, especially if we don't aim for improvement in the function. Botulinum toxin also helps in decreasing the the myelopathy. We should add gait training and gait aids, careful monitoring through serial radiographs of the lumbar spine to detect early changes that could lead to cervical myelopathy. Surgical options include segmental fusion if it necessitates. Efforts to minimize toe walking should be provided, and the use of appropriate orthoses is mandatory. Health-related quality of life and social participation. All these patients, from their young age, suffer communication problems. They cannot express themselves. So frequent follow-up with speech-language pathologists, and while examining all these problems like pain, cardiopulmonary, or bladder problems in our clinics regularly could help overcoming these communication problems. There is little known about how experience of aging, perception of health, and quality of life for people with CP. A review of literature on quality of life in older people has listed about 15 quality of life instruments. Among them is SF36 and European Quality of Life 5D. Take-home message: adults with CP are living longer, associated with improvement in the medical and surgical care. With aging, many conditions develop that can result in pain and significant loss of function over time. Communication barriers are especially significant for those adults who are nonverbal, requires augmentative communication devices, or have expression of pain that's not recognized by the busy clinician. Regular checkups and involvement of regular exercise program were reported to improve functional status, decrease the level of required assistance, and reduce the incidence of secondary conditions in people with disabilities. Thank you. And any questions?